We have HEMAC cases for the exam going students. It will be presented by Professor Reena Das and Dr. Srijesh Sridhar only, both from CGI Chandigarh. On the 15th of October, Dr. Anita Borges from the Center for Oncopathology will be taking up surgical pathology cases. So let's start. Dr. Neha Mittal, the stage is yours.
Thank you very much and a very good evening to everyone. Am I audible? So is my screen visible?
Yes. Yes, ma'am.
Is it moving? Is it moving okay?
No.
This is a blank sheet, ma'am.
Okay,
Blank
I will share again.
Yeah.
Share again.
Entire screen.
Entire screen. Yes?
Yes.
Yes.
Now
Yes, we can see yes.
Okay, great. Okay. Yeah. So shall we start?
you can open your PPT, ma'am.
My PPT is already open?
Yeah.
Yes.
Yes.
Sure.
Yeah. So Dhruv, can you start?
Neha, we can't see any. It's a picture only showing of deserts and dunes.
Yes.
Yes, ma'am.
You can start on the sand dunes.
Yeah, why not? I will just try another this thing.
Okay, Dhruv, can you guess? We are the best sand dunes in the world.
Sir,
Sand dunes in India.
yes, sir. In the Thar desert, and the best ones probably would be in the Sahara desert. I don't know how do you compare between best and.
Okay, so, don't say the best, better ones. What diplomatic answer you're giving now? Tell me, where's the desert in India?
What's it?
The desert in India.
So there's the Thar desert, and there are cold deserts like Ladakh.
Yeah, somebody, Dr. Rajni in the chat is writing Jaisalmer.
I tried sharing all the options.
When you click on the sharing, you have to share entire screen.
It says screen share. Yes.
Then you share your PPT. You can open your PPT, you can minimize your PPT, and then we can share your. I can see your screen, just top only, not the PPT.
So, okay, I think I will just minimize the PPT, I think.
Yes, you have to minimize it.
Yeah, so I'll minimize it.
And then share, and then maybe you can still.
So sorry for this.
It's okay. Sahara is another huge desert area in Namibia and Trans Africa, in seafood countries in Africa. So when you click on share, what happens, Neha?
I think ma'am has left.
Left, joining again. Okay. I think just bear with us 2 minutes. There's some sharing issues with our main teacher, Dr. Neha Mittal. We have 4 talks in the next this week 2 and next week 2, out of which 3 of them are for exam-going postgraduate students. So we have requested teachers to keep some simple cases and how to discuss the approach for exam-going students. And we have one seminar by Dr. Anita Borges. After that, we'll be starting HEMAT again, and we'll be starting leukemias, acute leukemias, AML, and molecular. We've already done the techniques, but we'll see how these techniques are applied. We'll have some maturation patterns in lymphoid lineage, maturation patterns in myeloid lineages. Now, these are the topics that postgraduates then you do not read and do not know. But if you are interested in HEMPAT or understanding concepts of maturation, we have excellent teachers in Prashant who will be talking about myeloid maturation, and Gaurav Chatterjee will be talking about lymphoid maturation. So how these cells mature in the bone marrow, and how do you identify them based on the pattern analysis by flow cytometry. So it will be an excellent session to attend, but it won't be an exam question for postgraduates. So this I can tell you. So if you're exam oriented, you don't have to attend. You want to learn good pathology.
Hello, ma'am.
Huh? Neha?
Yes.
Yeah, hi.
Hi.
Sorry for this. I'm trying again.
You click on share and entire screen. When you click on entire screen.
Yes, madam.
Yes, we can see.
Yeah, perfect.
Sorry for this.
No.
Thank you.
Yes, ma'am.
Thanks.
Okay.
Yes.
Yes,
Sorry for this. Yeah. Okay, Dhruv, can you start?
A 45-year-old woman with postcoital bleeding, cervix showed telescoping on perspiculum examination, pap smear taken.
Yeah. So anything from the history, Dhruv?
Postcoital bleeding in a premenopausal age patient.
Yes.
Yes. So, postcoital bleeding points to some kind of a lesion, probably in the cervix or in the vaginal wall, so something along those lines.
Yes, postcoital bleeding is most likely suggestive of a lesion cervix downwards, right? Okay,
Yes.
postcoital bleeding is not a feature of as an endometrial, right? Endometrial bleeding. Endometrial bleeding usually is in the form of heavy menstrual bleeding, irregular bleeding, postmenopausal bleeding, right? Postcoital bleeding indicates a lesion cervix downwards. Okay. Any other finding on perspiculum? We have said telescoping on perspiculum examination. Any significance of that? Anugrah, all the students are there, or is somebody not attending? Are all the students there?
No, madam. 2 students have not logged in.
Who are those?
Kasturi and Subiksha.
Kasturi and Subiksha. Okay, then Anugrah is there. Anugrah? Okay. Dhruv, you can only continue. So, any significance that you can attach to telescoping?
Again, suggestive of a lesion in the cervix. Telescoping.
Yes, no. Anybody else? So telescoping or barrel-shaped cervix is an appearance, okay, on colposcopy or perspiculum examination, which is usually associated with endocervical lesions. Okay, telescoping is a feature. When you have an ectocervical lesion, you see inversion of the transformation zone, you see ectocervical lesions, right? You see acetobite areas on the on the ectocervical region. But telescoping indicates that, or barrel-shaped cervix indicates an endocervical, usually will indicate an endocervical etiology. Right?
Yeah, we have 4 students. Anugrah is there, and Riyab is there, Sabiha is there, and Dhruv is there.
Yeah. I was told. I called out for Anugrah, but I think he didn't respond.
She's there. Anugrah, you there?
Yes, sir.
Yeah,
No.
Ishita, yeah.
Okay. So Anugrah, you go next. Yes. So what is this? This is the pap smear, right?
It is showing squamous epithelial cells with a pyknotic nucleus and intermediate cells.
No. Anugrah, let's go first things first. So considering all these pictures were from the same, right? From the same cervical smear. So let's
Yes.
report it like we would report a cervical smear.
Ma'am, first we'll go for the adequacy of the
Yes.
pap
That's
smear.
it. Yes.
We will first write specimen adequacy satisfactory for
Even
evaluation.
before specimen adequacy, what will you write? Even before specimen adequacy, what is supposed to be mentioned in the pap smear or in a report of cervical cytology? The type of processing. You always have to mention whether it's a conventional smear, it's a thin prep, or it's a short prep smear, because the criteria for adequacy will change according to the type of procedure that you're using for sampling your or for processing your cervical cytology. Correct?
Yes.
Okay. Then comes adequacy. Yes. So
Ma'am, we will write specimen adequacy satisfactory for evaluation.
why is it satisfactory?
Ma'am, we can visualize well stained and well visualized squamous epithelial cells are visible in this slide.
Very good.
There is no morphology is not obscured. It is well stained and well visualized slide.
Okay. And in this case, yeah. So can you tell us what are the adequacy criteria in general? Riyab, let Riyab tell that. Riyab, are you there?
I think Riyad is a little unwell also. Yeah, so I think
Sorry. Then Sabiha.
Ma'am, presence of squamous cells.
Ma'am, for conventional pap smear, we have squamous epithelial cells to be 8,000 to 12,000.
Okay.
For liquid-based cytology, we have 5,000.
5,000.
Okay.
Liquid is 5,000.
Okay, great. So supposedly, Sabiha. So supposedly this is the smear. Okay, I'm telling you these are pictures from the same smear, right? These are pictures from the same smear. So supposedly this is the smear, but you have, say, let's say 1,000 cells only in this smear. So will you report it as adequate? Yes, no. Sabiha, will this be reported as adequate? Yes, no.
But it does not meet the criteria. So as per the criteria, as per the it should be 5,000. Squamous cells.
So all these are from the same smear. So you are saying that it does not meet the criteria, so you will not call it adequate smear. Anybody else? Anybody?
The presence of atypical cells in the smear will we will give it as adequate.
Excellent. Okay. So you can supersede the criteria of adequacy if you are seeing atypical cells in the smear. If there are atypical cells, then the criteria for adequacy does not apply. Okay. Yeah. Excellent. Yeah. I'm getting a lot of responses from the audience, and yes, you all are right. Adequacy is trumped by atypia or atypical changes. Right. Okay. Anugrah, anything in this smear? What do you think in this field? You think it's a normal or an abnormal field?
Ma'am, there is presence of squamous epithelial cells, superficial squamous epithelial cells as well as intermediate cells. Superficial cells have a pyknotic nucleus.
Okay.
There are presence of neutrophils also in the background.
No, I'm asking you, is this smear showing a normal? Is this normal? Or is there something in this field also that you think should deserve your attention? Dhruv?
Ma'am, it is the cell in the center, ma'am. The blue cell has a small halo around it, but that's not it's not an irregularly shaped nucleus. So it's not very atypical, but yes, perhaps mild atypia, which could be because of the surrounding neutrophils and the inflammation.
Correct, absolutely right. So what you see staring at you is a nucleus which seems to be enlarged. It's not a typical pyknotic nucleus that you see in superficial squamous cells. It's enlarged and has a little halo around it. But this halo is not like a coilocytic, right? This is not like a coilocytic halo because you do not have the nuclear membrane irregularity. The halo is not to that extent. And this is not the only cell in the field. There is also a cell on the right lower hand side corner. Do you see? Even that nucleus has this little halo around it, but again not reaching the coilocytic level. So just at this, if you had only this picture of squamous cells in your smear, what would you call it? What would you label it?
Atypia of undetermined significance.
Yeah. So what is the terminology terminology that we use in cervical cytology? Anugrah?
Atypical of undetermined significance.
Ascus, right? Ascus?
Found.
Right? No, atypical cells of undetermined significance. Correct. So
Yeah,
ascus.
Yeah, can you use the laser pointer?
Yes. Okay. Okay, so this is, you see, this is what I'm talking about. Can you see the laser pointer on my screen now?
Yes, ma'am.
Yeah, and this is another thing that I'm talking about, right? These two cells, okay? So in just this group of some 20-25 cells, you have two cells which are showing you perinuclear halo, though none of these cells is showing a nuclear halo or nuclear features which are consistent with definite HPV related changes, right? It is somewhat lesser than that, but they seem to be frequent. So this is something that we can label as, just this can be labeled as ascus. But another areas of the smear or another smear that we had taken showed these. So, Sabiha, is Riyab back online? Feeling okay to talk about this? We have not talked to Riyab till now. If not, then Sabiha, I would like you to describe this.
Ma'am, what we can see overcrowding of cells.
No, first you have to describe what are these cells. What type of cells are these that you're looking at? In a cervical smear, what type of cells are these?
Squamous cells.
So, okay, Sabiha thinks that these are squamous cells.
Atypical squamous cells.
ECT is endocervical cell transformation zone.
Who's saying this? Anugrah is saying that. So, these are squamous or glandular?
Endocervical cells, not ECT cells.
Why do you say these are endocervical cells? Why do you say these are endocervical cells?
Because of honeycombing appearance of the cells.
Honeycombing appearance of the cells is okay. What else? Dhruv? So one, there is no prominent cell to cell border like you would see in a squamous cell. There is no definite keratinization. They are not in single cells. They are in groups which are almost forming papillary. Okay, which are almost forming papillary structures, right? And cell to cell borders are not prominent, right? So these are definitely not squamous cells. What we are looking at as glandular cells. Okay. The next thing is that they are more endocervical looking than endometrial because these are not small Okay, small, closely packed, right? Closely packed ball-like cells, which you usually see in endometrial, when you have endometrial cells, right? These are more open cells. These are cells with moderate amount of cytoplasm. These are well laid out. Okay, so these are cells which are more likely to be cervical cells. But other clusters, and including even that cluster, that amount of proliferation in an endocervical cluster, plus this, what is the special feature that this smear is showing? This photo is showing. How do you describe, Dhruv, this picture?
Ma'am, they're forming, I don't know, 3D clusters, or they're overlapping with each other. Then there's a columnar cell in the center. I can see it has a basically placed nucleus. Yes, ma'am, exactly where the arrow was. That was columnar cell. And
This is the cell column. Now what's happening? The cell seems to be jutting out, and
yes,
the other half of the cytoplasm is gone. So what is this? And then you said, what is this? Are the cells the same size? Are the cells the same size?
no, ma'am.
Yes, there's not the same size. So there is pleomorphism. So do they have any nuclear membrane irregularities? Do you see that? Can you appreciate the nuclear membrane irregularities, the anisonucleosis?
Yes.
Yes. So they have anisonucleosis, they have nuclear membrane irregularities. Okay, then they have nucleoli which have become prominent, at least in some of them. Okay, so then there is nucleoli prominence, and then this is also something that is a very important feature. Cell is coming out, one half of the cytoplasm seems to be gone, so it seems as the nucleus is jutting out of its cytoplasm. So what is this called? Anybody? So this feature is called fraying. Okay, this feature is called fraying, and when you have this fraying, then you are looking at a neoplastic. Okay, and in fact, fraying is a very important feature to look at malignancy in endocervical cells. Okay, so look for this fraying. This kind of fraying, when the clusters, the top half of the cytoplasm of the cells which are present in the clusters, the top half of the cytoplasm is gone, and what you have is just the nucleus projecting out at one. So this is known as fraying, and is an important feature of malignancy in endocervical cells. Endometrial cells are small, honeycombed, very compact appearing. You cannot look through those clusters. Okay, you cannot look through. These are more open now in this case with pleomorphism. Okay, so I was just coming to this, that this is so Bethesda system, and for ease of uniformity of terminology has to be reported in a certain pattern, and we were thinking of that. We were discussing that. So general will be negative for intraepithelial lesion or epithelial cell abnormality. So is this, where does this fit? In ILM or epithelial cell abnormality?
Epithelial cell abnormality.
Correct. So epithelial cell abnormality. Then we have to come to squamous versus glandular. In squamous we have ascus, L cell, H cell, and with H cell with squamous carcinoma, and glandular we have atypical, right? We have atypical. Then we have atypical, in which if you can specify if the atypia is in the endocervical or the endometrial, and if you cannot, you call it glandular cell NOS, right? And if there is atypia, whether it's favoring neoplastic. For example, in this case, you have features which are neoplastic, and then you have features which suggest you endocervical adenocarcinoma when they start forming glands, when they start showing clustering, when they start showing atypia in the form of nuclear membrane irregularity. But usually nucleolar prominence is not seen. And adenocarcinoma, when you see fraying, when you see nucleolar prominence, when you see pleomorphism, and atypia, which is more than in situ carcinoma, right? And papilloid clusters of large clusters with glandular differentiation. So where do you think this fits? This near?
Endocervical adenocarcinoma.
Correct. Yes, this is adenocarcinoma endocervical. Do not forget the squamous. What is the etiology in most of the endocervical adenocarcinomas? 70% of endocervical adenocarcinomas will be
HPV associated.
yes. Okay, so don't forget the first slide. If you remember, even the squamous cells here had some abnormality. Yes.
Yes.
And the pathogenesis will be the same, right? The pathogenesis will be the same. So if you have abnormality in the squamous cell, you have to mention that as well. Okay. Okay. So this is just to show you the different categories that we have, and what we do for these. So, the usual will be colposcopic biopsy, endocervical curata, DNC. Irrespective of the type of glandular cell. So if you just mention this, even the word of glandular atypia, the patient will go through the same. Because as I said, because of telescoping, a lot of endocervical glandular lesions may not be well visualized on colposcopic examination or on perspectival examination. So this is just to show you different favor AGC NOS, where you have glandular cells. You can't say if they are endocervical or endometrial. They're large. They are having a lot of cytoplasm, but they are not showing the typical characteristics of either endocervical or endometrial. There's no honeycombing, and these cells seem disconnected with each other. Right. Similarly, in the other picture also on the right hand side, they are forming a gland, but do not have typical endocervical leucine or with the columnar cell appearance is not there. Favor neoplastic. You can see these are forming almost ball-like clusters and showing nuclear atypia and mild pleomorphism. There is hardly any prominence of nucleoli, and this is just to show you other features of neoplasia. Adenocarcinomas, more prominent clusters, more closely overlapped, more ball-like 3D appearing clusters, more atypia and fraying. Okay, understood?
Yes.
And this is just to right upper hand side corner is the biopsy, which shows an endocervical adenocarcinoma. And this is just to show you the difference. If you want to see, look at the open and the amount of cytoplasm in your endocervical clusters vis-a-vis this case, which has more this kind of honeycomb. You see, you have cytoplasm and this. Okay, look at this, almost like this is more like a honeycomb kind of a cluster. Okay, which is more suggestive of an adenocarcinoma of an endometrial origin. The cells are very monomorphic, but very closely packed. The nuclei are round, and they are clustered or huddled together. The clusters will be dense, and you cannot look through these clusters. And on the right, you can see this is a case of endometrioid adenocarcinoma. Okay, so case 2, similar lines. Okay, Riyab is there. Subeha is there.
Sabiha is there? Sabiha, you can't hear it. I think maybe and Dhruv.
Okay, Dhruv.
Yes.
Okay.
Sabiha is there.
Sabiha
Can
is
you hear us, Sabiha? Sabiha. I can't think she can't hear us.
Okay, no worries. Dhruv, can you tell?
Yes, ma'am. So 47-year-old female, first speculum examination, no abnormality detected. Okay, pap smear was done.
Okay. Okay. So is this examination enough? I've said first speculum, no abnormality detected. Is this examination enough? Would you like to know something else?
Colposcopic findings.
even before colposcopic findings, colposcopy is a very you can say it is a technique based, it needs a skill based thing. Okay, what is more commonly done when we have cervical routine pap smear, routine cervical screening? What is done more often?
Pap smear.
No, pap smear is done, but after what? After?
HPV potency.
Yes, so after applying what on the cervix? How do you visualize the cervical areas?
Is it
Yes, so that is called
visual
inspection after application of acetic or Lugol's iodine. Okay,
Iodine.
Via and Willi. Okay, Via and Willi. So at least that much needs to be done, especially if it is a perimenopausal, postmenopausal woman. Those need to be done. Okay, so those will tell you things that your naked eye can miss regarding the findings on the cervix. Okay, okay, Anugrah, again. Dhruv, now your turn to you talk about the smear. Okay, Dhruv,
Yes, ma'am.
start with the how will you report?
Yes, ma'am. So first, adequacy.
Adequacy, yes. Is it adequate? Yes, no.
This is adequate, ma'am. We can make out all. We can the cells are properly stained. We can see the
Yes.
clear, and then there's abnormality, so we don't bother about the quantity as well, the number of cells.
Correct, absolutely right. So we can see that the cells have some abnormality, they have atypia. So this is adequate anyhow. Okay, yes. Then
So now
next,
these cells are arranged in clumps. They have a lot of cytoplasm, but however the nucleus is larger in size than as compared to normal intermediate
can
cells.
you give an idea of how much larger you have?
Around,
Some references here and there, to tell you an idea.
yes, ma'am, around 2.5 to 3 times as large. They are elongated. There is clear membrane irregularity, and you can see a prominent cytoplasmic halo around most of perinuclear halo around a lot of these nuclei.
Yes, and nuclear membrane irregularities, right? That is also very, very important. Okay.
Yes, ma'am.
So fine nuclei are visualized, which is okay. Fine nuclei can be seen, but there
And
are
some hyperchromasia also. nuclei.
correct. There is a focal hyperchromasia in some of them, and as I said, most importantly, there is nuclear membrane irregularity in these cells with a halo, with a very prominent halo with in a large number of cells. Okay, so both things are important. Halo is important, but halo can be present because of many reasons. Can you tell me halo can be present because of other reasons? Anugrah, can halo be present because of other reasons?
because of viral cytopathic effect. It can be
More common than that, okay, it can be present because of that, but more common than that, viral cytopathic is for HPV only, no?
Yes.
And what are the others? Yes, absolutely right. People in the chat box are absolutely right. Inflammatory, any kind of inflammatory lesion will also produce a halo. Okay, can also produce an inflammatory halo. Okay, it's called an inflammatory halo. It can be due to reactive atypia due to infection. But it is this combination of halo with nuclear abnormalities, with the size of the nucleus becoming more than 3 times as large, with nuclear membrane irregularities, with the amount of halo, with hyperchromasia, okay, which together guide us that this is not inflammatory halo. This is a neoplastic. Okay, this is a neoplastic halo, which is arising due to a viral cytopathic effect, right? Okay. Halo can be due to inflammatory conditions. So this is just to show you another clumped cytoplasm, almost like you can make it in with a kajal pencil around the entire area around the nucleus has cleared off. There are areas with nuclear membrane irregularity. Okay. So what is this? How will you classify this? How will you report this?
As LCL, ma'am.
So epithelial. Tell me the exact terminology that you will use.
So intraepithelial lesion.
Correct. Thomas epithelial. What, L or H?
L, ma'am.
Correct. L cell. Okay. Why not H cell? Why not H cell?
Because HCl will have even larger, lesser cytoplasm, then they not have this coilocytic, this perinuclear halo is not seen, and then the cells resemble parabasal cells and cells.
So that is the important thing here. The type of cells which are showing the abnormality. Okay, the type of cells which are showing the abnormality. Okay, Anugrah, that is important here. Okay, so when you have abnormality in the parabasal cells, okay, what you are seeing here are abnormalities in the superficial and intermediate cells. But when you have abnormalities in the parabasal cells, that is when you are thinking more in terms of H cell, right? And then the abnormalities will also be a shade worse, more hyperchromasia, more nuclear membrane irregularity, atypia, nucleolar prominence. All those will also be features of H cell. Okay, this is just to show you other lesions of the squamous. So mild halos, mild enlargement, this paleness of chromatin, and viral cytopathic effect leads to this paleness, this pale smudginess of chromatin. Okay, so in this superficial cells, this bigger nucleolus, right? So these are features which are atypical, but again, definitely not up to the level of L cell. This we just saw this. This was L cell on cytology, but on HPR it turned out to be a CIN2. Okay, it turned out to be a H cell on final histopath. So that also happens. Okay, so you may have areas which are missed or which are under recognized in cytology, and vice versa. It can happen. What about this? What about this smear? So Dhruv, Anugrah, what about this smear? Normal, abnormal? Anugrah?
And this looks normal, man.
Okay, yeah, everybody agrees with Dhruv? Same smear?
Some of the cells have enlarged.
Okay, so you see this, okay? You see this, and you see this, okay? Do you?
Yes, ma'am.
So what size of cells are these? What are these cells?
These are parabasal cells.
Correct. You see this parabasal cell with this amount of pycnotic nucleus, and nuclear membrane irregularity. Okay, so this cannot be missed. Okay, this cannot be missed. Okay, so like you see in this case, these cells are very, very scattered and far in the smear, right? They're very, very few in the smear. So if you get this smear, what will you report this as? But they have abnormalities which are far and beyond, except for L cell, right? They're not in those cells. Okay, so these are not like L cell abnormalities. So what is this to be reported as if you get this?
So atypical squamous cells, H cell cannot be ruled out.
Ask H. Okay, this is an ask H. High grade atypia appearing cells, but very far and wide scattered within the not enough number of cells or not enough number of atypia. Okay, enough amount of atypia to call it an H cell. Okay, and this sure enough on biopsy, other smears which are which have been called as ask H. Okay, because you had L cell like areas, you can even call this when you have L cell like areas, but you also have abnormalities in parabasal appearing cells. Okay, when you have abnormalities in parabasal appearing cells. So in such cases also this terminology can be used, and then This on cervical biopsy turned out to be a CIN3. And this, if you see, has diffuse abnormality in the parabasal cells, very high grade atypia. Okay, very high grade atypia. So good enough to be called as
Excellent.
Edsel. Okay, before calling this Edsel, Anugrah, what is the background here that you notice? You see the background here, you see the background here, okay? And you see the background here. What is the difference?
Neha,
Hanji?
Kasturi has joined. Dr. Kasturi has joined.
Okay, Kasturi has joined. Great. Hi, Kasturi. Yeah. So, Kasturi, would you like, let us just settle. Okay, maybe I'll ask her the next case. Okay, so Anugrah, do you see the background?
There is a dirty.
Dirty. And what is this dirty reddish thing due to? No, this is like a leached out, almost like leached out protein from blood. Okay, this is leached out, and sometimes it may get mixed with necrotic. Okay, necrotic. So please pay attention to the background. Okay, please pay attention. The background can make a difference between calling something as in situ versus invasive. Okay, so if this had more amount of necrosis, if this kind of hemorrhagic proteinaceous like background starts appearing, dirty background starts appearing. Okay, sometimes these smears may just have this overwhelming amount of this background with very few scattered cells here and there. You cannot call them inadequate. Okay, they are actually what? They're actually squamous carcinoma. Okay, this tumor diathesis is very, very suggestive of a squamous carcinoma. Okay, so be very careful. To look for this tumor diathesis. Again, very, very high grade clusters. Okay, very, very high grade looking clusters. So very good to be, or this is the setting in which you will call it Edsel. You can in case there is tumor diathesis, for example, in the left half, the bottom left half picture, there is this necrotic mixed material along with your atypical squamous cells. You can also say that squamous carcinoma cannot be excluded. And if there is an extensive tumor diathesis in the background with those pignotic tadpole type cells, then you can label it as squamous carcinoma. Okay, it is important to know the cervical first speculum findings. Usual cervical carcinomas, squamous carcinomas will present with a mass lesion. So if you have a good colposcopist or a good person who was examined and they say no abnormality or only acetobite areas and no mass lesions, then be very wary of calling it a carcinoma. In that case, just if you're, but at the same time, if there is a mass lesion, you should very carefully look for the carcinoma cases because most of those cases, Edsel will not produce a mass lesion. Okay, Edsel will not produce a mass lesion. So what you're looking for are squamous carcinoma cells in that case. Okay, great. So we go to case number 3. Okay, Kasturi has joined.
Yeah, she joined, but I do not know if she has muted herself.
Okay, anybody except Dhruv and this one, Anugrah? Anybody else there?
Yeah, ma'am, I'm here.
Oh, Kasturi. Okay, can you read this out for me? Have you been able to see the cases?
Yes, ma'am.
Great. Can you just please read this out?
Yeah. So a 30-year-old male with a 3 centimeter swelling in the neck, which mixed with deglutition.
Okay, so what does this tell you, Kasturi? What does this tell you? What does this tell you?
It could be a retained.
No, what I'm asking is what does this tell you about the site of the swelling? Where do you think
thyroid?
Correct. This is a very characteristic clinical finding of a swelling in the thyroid.
Thyroid, yes, ma'am.
Okay. So, okay, great. So what you're looking at is a mass in the thyroid.
Yes, ma'am. So on examination, a 3 centimeter mass in the right lobe of thyroid, which was forming consistency. And on USG, the mass is hypoechoic with central and peripheral macrocalcification. That's what was found.
So based on these features, Kasturi, do you have any idea that what should be your clinical impression of this thyroid swelling? What history is missing in this case, if you would like to know that, and whether or not you should go ahead and FNA this swelling? And if yes, why? What in this is telling you?
The duration is
very excellent. Yes. Yeah. Okay. So the duration of the swelling is not there. Okay. And that is an important finding. That is an important history. Okay. Yeah. So why is it important?
Because it's a firm in consistency, so it might signify the calcifications maybe.
Basically, duration will tell you the rate of growth of that lesion, right? So patients will notice when they, when those things, duration will tell you waxing and waning course. Yeah. Patients will say it goes out, it becomes big, it becomes small. Then you're thinking of thyroiditis. Okay, duration will tell you if it was small and if it is rapidly growing. They will say
Anaplastic
has been. Yeah. So anaplastic is very far-fetched growth, बहुत extreme हो गया, है ना? But what you need to know the rate of growth. So it is important to know the duration. Okay. So this swelling has been there for 6 months. Okay, this has come up for 6 months. Okay, and okay, now I'm asking you that what are the features in this history that indicate? Okay, please understand pathologists are first and foremost clinicians. Okay, and sometimes we have to be better than our clinicians. Okay, sometimes we have to. In fact, we always have to keep guiding. Okay, regarding the management. So don't think we are lab people. We are no longer lab people. Okay, we are actively managing patients. Okay, in terms of their histology, history, predictive, prognostic markers. Okay, so understand your new role and act accordingly. So tell me, as a clinician, do you think this needs to be taken up further?
Yes, I feel that.
Yes. Okay, you feel why?
Because it's been there for quite a long, for 6 months, and we.
See, as far as the duration is concerned, yes, it is the reason. But when you talk about thyroid, 6 months is nothing. You know the common joke that if God says you can have one cancer, ask for papillary thyroid carcinoma, because you're likely to die with it rather than because of it. Okay, so it is like that. So it can happen. It is usually there for years. So actually, 6 months is a very short duration for a 3 centimeter thyroid swelling to come up. Okay, so that is why it is worrisome. Okay, it is worrisome in that way. So what else?
There is hypocalcification of ultrasound.
Excellent. So there is central and peripheral. There are macro calcifications which are present. More important than that, the nodule is hypoechoic. Okay, the hypoechogenicity is a feature. Hypoechogenicity is a feature which is not good for thyroid lesions. Okay, hypoechoic lesions should be before that 3 centimeters. So what is the current recommendation? So based on, of course, it is based on characteristics also, but in any thyroid lesion which is more than 1 centimeter, you are justified to FNA it. You are justified to FNA it if it has other features which are suspicious, right? Less than 1 centimeter mass can be left alone if there are no suspicious features of malignancy or of abnormality on ultrasound scan. In this, the features are male. This is a solitary thyroid nodule in a male. Okay, immediately it should alert you. Okay, it's SCN in a male. Okay, then increase in 6 months. Okay, 3 centimeter size, hypoechoic, central peripheral calcifications. Okay, and then somebody said any serological investigations that you would like?
Calcitonin.
thyroid function test, yes, most of the patients will get done when they have thyroid swelling, but the others usually you will not get that information upfront. Okay, you will not get that information. The thyroid function test in this case were normal. Okay, were normal. Okay, so what is this? Kasturi, can you describe?
Yes, so we can see
From thyroid.
thyroid follicular cells, which is an adequate smear because we can see more than 10 groups of each of 5. Each of, yeah, more than 6 groups of, yeah, and the background is mixed. I mean, mixed hemorrhagic and
this is a proteinaceous appearing.
Yeah.
Proteinaceous. But you said these are follicular cells. Yeah, you're saying these are thyroid follicular cells. This is the higher part.
yeah, at this part it looks like follicular cells.
Okay, anybody else? Dhruv, Anugraha, you agree these are follicular cells?
Ma'am, these look predominantly dispersed plasmacytoid type of cells.
Excellent. So, Kasturi, these are not follicular cells. Okay, they are not arranged in any follicle. You see, these are practically papillary to not exactly papillary, but these are cells which are more disseminated with some groups. Okay, more disseminated.
Yeah.
More disseminated with some groups. And what do you see? These are capillary-sized channels which are coursing through these clusters. These appear vascular. Okay, so vascular, yes, there is no follicular architecture. They are not arranged in small round follicles that you would expect follicular cells to be arranged in. Okay.
Okay.
These are predominantly dispersed. So now we see that this is the higher part. Okay, Kasturi, can you describe now the higher part? You see the dissemination of cells?
Yes, ma'am.
Yes.
So there is moderate pleomorphism in the cells, with few of them showing scanty amount of cytoplasm.
Yes. Any characteristics to the cytoplasm? Any characteristics to the nuclei?
There is granular salt and pepper appearance of chloroplatin.
There is salt and pepper appearance. Yes, some cells do have that. Correct. I agree. Some cells do have that salt and pepper type appearance. But more importantly, what do they not have? What they don't have?
They don't have nuclear clearing.
Correct. So they do not. They have nucleomegaly. Of course, this is not the normal nuclear size of a follicular cell or any other cell in thyroid. Okay, but what they don't have are nuclear features of PTC, right?
Yes.
So what are nuclear features of PTC, Kasturi?
Nucleomegaly, nuclear clearing, then coffee bean shaped nuclei, groove.
Correct.
Pattern.
Right. Very good. Very important. First, the pattern is very important.
And also the inclusions.
But very importantly, one very important feature, most important, is clearing. Okay, and the inclusions. Okay, clearing means you can actually look through those nuclei. They're that pale. You cannot look through these nuclei. What features they have, and you should know that even this tumor can have those features. It definitely does have convoluted nuclei, which at places gives you this intranuclear inclusion, like this. You see this intranuclear inclusion. You can actually see the cytoplasm from within the nucleus, right? These cells also have intranuclear inclusions. Okay, then they have nuclear grooves. Then they have these sudden large cells, which is known as sudden
Anisonucleosis.
They have this wispy, very granular appearing cytoplasm, which seems to be getting stripped off in many of these cases, many of the cells. Okay, this is just to show you the GIMSA. GIMSA is much easier, so to say, to interpret in this case, which shows you the plasmacytoid nature. Okay, the sudden anisonucleosis, the nice plasmacytoid nature of these cells. Some groups, but predominantly disseminated population of cells. So, what are your thoughts? How will you report this? Dhruv?
Yes, so this would be malignancy, Bethesda category 6, ma'am.
And you will not classify further?
Yes, ma'am. This is suggestive of medullary thyroid carcinoma cancer.
So, positive for this is malignancy, right? And subtyping is medullary thyroid carcinoma,
Yes, ma'am.
right? And Bethesda category is
6.
correct. Okay, everybody agrees? And what instructions will you leave for your clinicians?
Check the serum calcitonin.
Check the serum calcitonin levels. And what else?
Do genetic testing for that.
Okay, first check the serum calcitonin levels. And supposedly, do you understand calcitonin levels are not available in every lab, right? Even calcitonin levels are not available. So is there something else in the serum markers which can also give you an indication of this entity? Is there something else in the serum which will be abnormal in these cases and highly abnormal?
Calcium.
No. Why?
Parathyroid.
This is not parathyroid. This is not parathyroid. No, PTH is wrong.
CE levels.
Correct, absolutely right. It is CEA. So medullary thyroid carcinomas, before calcitonin in the serum, calcitonin to be measured or calcitonin was found to be secreted, would be diagnosed based on CEA. Okay, CEA levels are abnormally high. If you see gastric cancer patients, all that, most of those patients will have CEA in 20s, 30s. The usual CEA levels are up to 5. But if gastric carcinomas and all will also have CEA up to 20, 30, like that. But medullary thyroid carcinomas can have CEA in hundreds and thousands. Okay, so CEA is also an important serum marker for medullary thyroid carcinoma. And the other one is calcitonin, of course. Okay, parathyroid can also have an oncocytic predominant picture on cytology. Yes, it can have those oncocytic appearing cells with neuroendocrine features, but usually will not show you these intranuclear inclusions, will not show you this degree of, so to say, chromatin abnormalities that you see in medullary thyroid. But yes, in a particular case, it can be difficult to distinguish. Also, as I told you, why I made you compare features of PTC versus medullary is because oncocytic papillary thyroid carcinoma your oncocytic cells when you have in papillary thyroid can also come like this as a very disseminated population, and the two can be oncocytic PTC and medullary can be very difficult to distinguish because oncocytic PTCs may not have all features of PTCs, right? So that is also a differential on cytology, in which case in certain cases you may have to ask for serum calcitonin levels to distinguish. But most of these cases will show you features which are classical. You can have spindle cells. Spindle cell subtype is also there for medullary, so you can also have spindle cells instead of these oncocytic or plasmacytoid cells for medullary thyroid carcinoma. You can have presence of amyloid in the smear itself, right, which can also indicate towards a medullary. And this is just to show you the final histopath of this case. Very plasmacytoid appearing in this case, and this is on the right is the serum calcitonin, which is diffusely positive. Okay, just a word about medullary thyroid carcinoma. It has changed in the recent WHO, where you now should know that it has to be classified on histopath also. There is now an international medullary thyroid carcinoma grading scheme. So it does not suffice to just call it medullary thyroid carcinoma. You have to say whether it's high grade or not. There are two types of medullary now: medullary thyroid. It's not called low grade, and high grade medullary thyroid. So high grade tumors will have one of these features: necrosis, mitotic count more than 5 per 2 mm square, and or a P67 proliferation index of more than 5%. So besides your usual calcitonin, synaptopromo, PDF1 pack set, these days it's must to do mitotic count on morphology, look for tumor necrosis, and do a proliferation index on histopath. And this is a seminal paper which validated this grading system. This is from the MSKCC group, and they showed the validity of this system in 5 different sets of patients from 5 different centers. And now it is accepted in WHO and CAP guidelines to grade medullary as medullary and high grade. And this is just to show you the different categories of the Bethesda system for reporting of thyroid cytology. We must speak this language. Each and every smear of thyroid cytology should be reported into one of these categories. Okay, so this is non-diagnostic, cyst fluid only, benign, follicular nodular disease, which includes your colloid nodules, Hashimoto's thyroiditis, atypia of uncertain significance, undetermined significance, and you have to specify there's nuclear atypia, follicular neoplasm when you have microfollicular architecture, suspicious for malignancy when you have some features but not enough to label it malignancy, and malignant when you can classify it into any of these features. Now, what category of tumor is very prominently missing from this? Kasturi?
Yes.
Among the malignant category, one malignancy of the thyroid is very prominently missing. What is that? Which type of malignant thyroid carcinoma is missing from this?
Follicular.
Follicular.
Follicular. And why is it missing, Kasturi? Why is it missing from
Because we can diagnose it only on histology, because the capsular invasion is something that we need, and we can't talk about it.
capsular? Only capsular or one more? One more? Anugrah?
Extra.
Capsular and angio. Okay, angio invasion. Okay, capsular and angio invasion. Okay, these two characteristics, these are two criteria for malignancy in follicular neoplasm, both of which cannot be evaluated on cytology. Hence, malignancy of a follicular carcinoma. We cannot make a diagnosis of a follicular carcinoma on cytology alone in majority of the cases, right? In majority of the cases. Why I say majority of the cases? If the patient is already a known case, if you know clinically that the patient has a metastatic lesion, then yes, you can say that in view of clinical features, we are considering. But otherwise, for all practical purposes, follicular carcinoma is not a diagnosis that you will render on cytology. Okay, and why I call it angio invasion? Because it's different from lymphatic invasion. Okay, so these are terms that you need to know when you're reporting thyroid. Okay, so now whose turn is it? Anugrah. Last case.
40 with enlarged left cervical lymph node measuring 3 cm. On examination, the node is firm and fixed to the underlying structures. The examination of buccal mucosa revealed dark discoloration of the mucosa and a 1 into 1 cm ulcer in the left gingiva buccal sulcus.
Okay. So what do you make out from this history? Anugrah, what is your thought process as a clinician when you look at this history, or when you have done this, or you have done this history and examination? Okay. So
One 40-year-old male with an enlarged lymph node, which is fixed and firm to the underlying structure, will point towards a malignant tumor.
okay,
He is also having an ulcer in the buccal mucosa with dark discoloration.
okay.
They point towards a malignancy.
So there is a node which is firm and fixed. Okay, to underline, as you said, this is an abnormal finding. Okay, this is an abnormal finding, and this fixation to the underlying or surrounding structures indicates what? That whatever is the pathology has grown outside of the lymph node, right? Yes, it has shown that there is. So even in tuberculosis, you can have matted lymph nodes. Okay, you can even have matted lymph nodes in tuberculosis. This just indicates that there is extension of the disease and disease-related fibrosis, and a disease eliciting fibrosis, which are extending to surrounding structures. At the same time, when you see something like this, you understand that there is a risk of malignancy. So you will examine everything that is in the draining side of that. Okay, and that is why the buccal mucosa examination was done. Understood? And then it reveals a 1 into 1 centimeter ulcer. So, okay. So, this is the cytology of this. Okay, Dhruv?
Yes. So, so these are slightly discohesive cells with
Not slightly, Dhruv, these are discohesive cells.
okay, these are
These
discohesive.
are not showing any. Each cell is not looking. These 4 cells are talking to each other, but every other cell is looking at in some other direction. Okay, so these are not showing any cohesion. Okay.
So they have amphiphilic cytoplasm, and the nucleus is very eccentric in most of them. There is prominent anisonucleosis. There is some of these nuclei have very large nucleoli. You can see it at the top.
Yes, you appreciate even in the gene stuff, you can appreciate presence of macronucleoli. Okay, and plasmacytoid appearance and a singly scattered population. Isonucleosis. Yes, some cells will appear to be large, bizarre. Okay, and they have prominence of what is the usual? What is the usual? What is this appearance called? What all tumors do you think you can get this kind of an appearance on cytology?
Ma'am, because of the nuclei, the sheer size of the nuclei, I would think of a melanoma, and it is correlating with that discolored patch and ulcer as well. So that's the first thing that.
Okay, so now you have correlated it with discolored gingiva buccal sulcus. Excellent. Okay, forget that was there. Okay, maybe that was not there. Okay, I did not give you that history. Actually, I was contemplating whether or not to give you that history, but I saw most of you are JR1s and 2s, so that is why I gave that history, because I didn't want the discussion to go really haywire. But anyway, if you don't have that history, then what all these cells could represent? What all what are the other?
Macronucleoli are also seen in lymphoma and melanoma.
Melanoma I've seen. Lymphomas, yes, it can be seen, but lymphomas will have more LG bodies, lymphogranular bodies in the background, right? So what else? Germ cell tumor. People are putting in the chat germ cell, very prominent background of necrotic, a very necrotic background may be seen. Okay, in germ cell tumors. So otherwise, yes, these kind of cells can definitely be seen, but you will look out for this thing. These days, you have to keep in mind rhabdoid tumors. Okay, rhabdoid tumors we can also, and even oncocytic, anywhere where you can have an oncocytic histology, these tumor cells can represent an oncocytic histology. Though this amount of prominence of nucleoli will be uncommon, but then this histology overlaps with oncocytic. Okay, oncocytic histology, oncocytic cytological features as well. Okay, so depending on the case, depending on the site, these are the different differential diagnosis that you may consider. But yes, as you say, in this case, the prominent nucleoli, the nucleoli which appear to be staring at you, okay, most of which are single macronucleoli, some having multiple nucleoli. These are the features which are pointing in favor, and plus your good medical examination, which told you that there is a 1 into 1 centimeter gingivobuccal sulcus lesion as well. Okay, so it points you in the right direction, which is this. Anything else in the cytology that you will look for?
Ma'am, pigment. We can see pigment in any of the smears.
Yes. Sometimes you will have to look very hard. Can you see it now? it is an abnormal malignant cell, है ना? And what does it have? It has this black. Okay, this is not hemosiderin, this is not golden. Okay, so sometimes you will have to look very hard for the pigment. In amelanotic melanomas or largely amelanotic melanomas, the pigment may not be, or you can have extremes where all the cells will be covered by pigment. So look very hard when you are having this differential, you may be rewarded. So there is pigment in some of these cells in cytology as well. Okay, because if you have pigment, then you can be very sure you are dealing with a melanoma. Okay, this is just to show you the histology. This is the ulcerated lesion from the gingivobuccal sulcus, again groups of cells. Here also it can be a differential of a poorly differentiated squamous carcinoma. Okay, so you have to learn to pick up this case in the sea of squamous carcinoma that will come on your table. So this you have to see that it does not have any obvious squamous differentiation. It is odds or nests of highly malignant cells with prominent nucleoli. Okay, S100 also in this case was very weak and focal. So you must remember some cases may not show you S100, but this case was showed diffuse positivity for other melanoma markers like this one. This is HME45. So this is a malignant melanoma. Okay, of the buccal mucosa which has metastasized and produced that cervical mass. The buccal mucosa mass was very small. So this kind of covert or carcinoma of unknown origin type of presentation of melanomas is also very well known. Only when you think about this entity will you diagnose it correctly, right? Right. I think I'll stop there. Okay, and I also take this opportunity to invite everyone to our head neck pre-conference workshop, the head neck oncopathology masterclass on 17th of October, which is part of FHNO 2024. It is just around the corner. It is going to be a day full of head neck oncopathology, and I invite you all to come and attend and be a part of this conference as well. I'm thankful for this opportunity to talk to all of you students. You are excellent. I had a very good time discussing these cases with you. Thank you.
Thank you so much.
Thanks a lot.
Thank you.
Thanks a lot.
Thank you, Dr. Neetu, for the excellent.
Thank you. Any questions or anything?
So I saw a question in the chat box. One student was asking how do you describe the nucleus of the thyroid MPC that you presented. A student was asking that.
Yeah, so MPC nuclei. So as I said, they can have salt and pepper because they're neuroendocrine, neuroectodermal neuroendocrine cells. So they can have a stippled or a salt and pepper, what we call a stippled chromatin, and they can have they have sudden anisonucleosis, means you have cells which are almost of uniform size, and then in between you have cells which are suddenly large or look like giant cells. Binucleation is a feature which is seen in medullary thyroid carcinoma. Fine nucleolus may be seen. Intranuclear inclusions will be seen in this plasma cytoid. To spindle cell can be the nature of the cytoplasm. When you have spindle cell melanoma, the nuclear features may not be very forthcoming. Okay, but there are not many spindle cell lesions that you see in the thyroid, and when you see a spindle cell lesion, you must have medullary as in your differential.
Thank you, ma'am. I don't think there are any other questions.
Okay, I think it was too simple. But,
One question we have: how to differentiate hemocytoid macrophages and melanocytes?
So hemocytoid macrophages usually have this a golden or a golden brown pigment, whereas melanoma pigment is very black in color. Okay, it can be a problem when you're actually having a lung biopsy where you have the anthracotic pigment, which can have the similar histology. So even when you don't have the primary, you have good cells which are showing melanin with features of malignancy in the form of these prominent nucleoli, these single cells, these highly atypical cells. So then in that case, you can give this impression directly. In other cases where pigment is not there, the nuclear features are suggested. You may suggest this diagnosis and ask for biopsy for confirmation using immunohistochemistry.
Ma'am, how to identify reactive atypical pap smears due to malignancy or inflammation?
So as I said, it is inflammatory lesion. So dyskeratosis is a very short sign of HPV related cytological atypia. Then halos, halos which are accompanied by nuclear changes in the cells which are showing the halos are hallmarks of HPV. Halos which do not have the associated nuclear features are likely to be inflammatory, especially if they are present in a large number of cells and the similar kind of halo. So when you see a smear at low power and you see all the cells showing some amount of halo, think more in terms of an inflammatory rather than HPV associated. Okay, an HPV associated halo is much more prominent. The cytoplasm is reduced to a like a condensed thing at the periphery of the cell, and your nuclei will show you abnormalities. The nuclei will not be normal.
Okay, thank you, ma'am.
Thank you.
Stop sharing your screen now. You have already stopped. Okay.
Yeah. I'm sorry for being able to start the meeting, late because of the technical issues with my